Hello. So, see, I'm covering portion on X-rays and orthopedics. I'm Dr. Swapnil Kenny, and I'd just like to thank Dr. Kapil Pawar for sharing a few of his slides with me for this presentation. Now, we'll be dealing with X-rays in and out during the exam. So it's not only of the table vivas, because all your long cases, short cases, everywhere. Like even in our case, the presentation right now, we dealt with X-rays. So what we are going to deal with is how do we request for an X-ray, how do you read it, and how to make a diagnosis out of it. So requisition. So now we all know all this. We always take two views, orthogonal, two joints above and below, two times X-rays, acute and delayed. I'll come to that. And sometimes we also ask for an X-ray of the opposite limb, especially tomorrow when we cover in pediatric population. Many of the time we ask for X-rays of the opposite side as well for comparison. So this is like an X-ray, an AP of the elbow, wherein sometimes we not find any pathological diagnosis, but then in the lateral view, you come to know that there's a fracture. Anyone? What can this be? Capital. Yeah, so there's a capital fracture. So definitely an orthogonal view is what is required. Now, why we require up and joint? So they're very simple, What is our diagnosis? Anyone? What? Yeah, comminuted shaft femur fracture, right? Yeah, how will you manage this case? Nailing, correct. Close interlock nailing. No, but yeah, so we want to X-ray of the hip joint because that is what the patient also had. So now how you manage this hip fracture? Anyone? Anyone? Okay, chalo, no issue. We'll go ahead. Okay. Yeah, what is this? No one that I have to point out. Normal X-ray. Okay, so there's an undisplaced sort of a lateral condyle fracture over here in a child. That's how you appreciate it. Because then, now why I said sometimes we require X-rays acute and delayed, because this is what happens. The child came to us 2 weeks later and that time it was displaced. So you need to identify, as orthopedic surgeons, definitely you should be identified at this stage and not leave the child to come after 2 weeks. So definitely acute and delayed sometimes. And we require sometimes X-ray done for both sides, the affected as well as the normal. So how to read an X-ray? So this is the traditional teaching, the A, B, C, D, E. You start from whether the X-ray is adequately exposed, the alignment, the bone, cartilage, disc, environment. Remember, this is not hard and fast to be followed. Sometimes what you do is, as it is taught in the spine cases, if you remember, either go from anterior to posterior or posterior to anterior. Similarly, in the hip cases, either you start from the soft tissues, go to the joint, or other way around. Okay. Soft tissue reading. So, anyone? The madam, yeah. Can you read this X-ray for us? Anything positive in that? I've given you the hint as well. What is that? Yeah, that's a fat pad sign. Okay. So just in front, you have a fat pad sign which is seen. Okay. So do not always look concentrate upon the bone, sometimes even the soft tissues and this fat pad sign. So how do you report your findings? The type of the X-ray, plane, contrast, arthrogram, which view it is, AP, lateral, oblique, which is the part. Always talk about anatomical area like X-ray of the thigh, X-ray of the ankle, and not X-ray of the tibia, distal tibia. Okay, and the age of the patient, whether it's a mature skeleton or immature skeleton. What is the pathology being seen? Where is the site of the lesion, epiphysis, metaphysis, diaphysis, medullary changes, cortical, periosteal, and the soft tissue. We'll come to this one by one. Okay. So X-ray reading and exam is all throughout, whether long case, short case, as well as in your vivas. So a typical hip long case. Anyone would like to read this X-ray? Let's start one by one. The person in blue, yeah. Can you read it for us?
This is a X-ray of the pelvis bone with
pelvis with both hips. No need to say sacrum and all. Ek koi to bola tha aaj. Yeah.
With adequate exposure.
Yeah.
The left hip joint is sclerosed.
Okay.
The left femoral head is sclerosed with an irregular head.
Yeah.
Loss of sphericity.
Correct. Joint space.
joint space is decreased.
Shenton's arc.
Shenton's arc is maintained.
Okay.
Broken. Okay.
Shortening.
There is shortening of the left side by the level of the LT.
Okay. Fine. So just remember one thing. Whenever X-ray has been shown to you, always and always take 5 to 10 minutes of pause. Analyze the answer first in your brain. Most of the times, or at least 50% of the time, you may have seen the X-ray before. So don't jump on to start examining them. Even in your exams, take a pause, look at the X-ray. So the examiner feels that you're seeing it for the first time. Read properly and then you start. Short case. Anyone? Simple. What probable short case can this be? Yeah. Anyone? The one in red?
Hello.
Yeah.
This is a plain X-ray radiograph showing elbow.
Yeah.
EP and
what do you think with a child, adult, mature skeleton, immature?
In an immature skeleton.
Yeah. Okay.
Here we can see there is probably deformed distal humerus.
Okay.
Maybe suggestive of an old fracture.
Correct.
Most probably supracondylar fracture.
Yeah.
Now in having malunion.
Okay. If I ask you a theoretical question, malunited supracondylar fracture, what are the deformities that you see, doctor?
The patient will have gunstock deformity.
Yeah.
With
and
cubitus varus.
Varus and in the sagittal plane.
And you'll have extension.
So comment upon all that. There is a hyperextension of the distal fragment. There is a varus of the distal fragment that you see. So most likely, as you rightly pointed out, a cubitus varus deformity due to a malunited supracondylar humerus. So in our presentation today, because all our long and short cases are mainly getting covered, I would like to have a little bit more detail on the tumors, which X-rays are normally kept during your table vivas. So like how we described previously, but here we'll be more concentrating on the site, the lesion, the cortical changes, medullary and periosteal reaction. So just a few theoretical slides first. So most common lesions which we see. So in the epiphysis, we have a giant cell tumor, chondroblastoma. In the diaphyseal, we have Ewing's, fibrous dysplasia, osteoblastoma, lymphoma. So different type of lesions, but distribution wise in the epiphysis and the diaphysis. So again, a very common figure which is given on almost every of the books. So the epiphyseal lesions like chondroblastoma, one in the physis, giant cell tumor very close to the physis is what you can get. Metaphyseal region, osteosarcoma, or solid or SBC or an ABC, which can be seen over there. Similarly, another slide for what are the central lesions, what are the eccentric lesions. So centric lesions are mainly enchondroma, which is very commonly the diaphyseal, metadiaphyseal area in the center. Eccentric lesions like ABC or a GCT, and cortical and paraosteal. Just go ahead. So how many lesions that you see, the number, the nature, whether it's lytic or blastic. We can take a photograph of this slide. Okay. So with respect to the age of the patient and what kind of lesions are there, just remember them so that you can give your differential diagnosis. Okay. So depending on the age of the patient and the nature of the lesion, whether it's lytic, blastic, or aggressive looking like, and then you have like less than 20 years aggressive can be an osteosarcoma. Non-aggressive, there is a mnemonic given for you, A to F. Okay. Cortex. So it can be expanded, scalloped, or eroded. So cortical erosion, like destruction of the cortex. Any lesion where you see a destruction of the cortex commonly, any lesion. Yeah, any malignant lesion like osteosarcoma if you have. Yeah. So when you're describing the X-rays, remember you have to use this particular term, whether there's a cortical erosion, whether there is an now this lesion, which is an endosteal scalloping. So there is no cortical breach as such, but the cortex has been eaten up from within. That's an endosteal scalloping from an intraosseous process. This you can see in an intraosseous abscess in an osteomyelitis. Okay. The matrix of the lesion, where it is clear, I think there was some discussion on ground glass appearance. Okay. Whether there's a calcification inside, cartilaginous or osseous. So when there's a cartilaginous tumor, any cartilaginous tumor, anyone? Yeah. So these are the type of calcification that you see inside, whether a stippled calcification, flocculent, or a ring and arc type. So patterns of mineralization on a bony matrix. On a bone, it can be solid calcification, a cloud-like or an ivory-like opacity. Zones of transition. Anyone? What is zone of transition? Normal to? Can be a little more specific? Yeah. Yeah. So what does it tell you? Okay, yeah, exactly. So narrow zone of transition versus a broad zone of transition, let us see, and the pattern of destruction, whether it's geographic, moth-eaten, or permeative. So this Ludlow's classification, this is mainly for geographic type of lesion. So whether it to type 1A, where it is well defined with sclerotic in margin. So that margin which you see inside, okay, the sclerotic margin well inside. Then geographic destruction well defined but no sclerotic margin within, and geographic destruction with ill-defined margin, which shows increased aggressiveness of the lesion. So patterns of bony destruction. So all three figures put together. What is geographic type of destruction? What is the moth-eaten type? And what is the permeative type going all the way down to the diaphysis? Always remember there will be some amount of overlap between moth-eaten and permeative at times. Okay, and no one's going to fail you because of that. But you need to use those lesions, especially when you're talking about a pathological fracture. And if you have a case very similar to that, and the X-ray shows it, so use these terminologies. You will invite questions from the examiners, and the answers will be ready with you. What are the types of destructions and otherwise? And obviously, the geographic ones commonly are the less malignant one, and the permeative ones are more malignant. Periosteal reaction, again, different types: solid, lamellated, spiculed, Codman's triangle, commonly seen in. Yeah, so very, very aggressive type of lesion. So then whenever you see a lesion like a tumor, we need to locate where it is in the epiphysis, diaphysis, metaphysis. What is the appearance of the lesion, whether it is centric, whether it is in the centric or eccentric, appearance of the lesion, whether it's lytic or blastic, number of lesions, whether it's solitary or multiple, what is the matrix, what is the zone of transition. So these are the headings between which any type of lesions you have to describe. Okay. And periosteal reaction. Anyone? Chalo. No. I want a little better now. After explaining all this, I should not get an answer. This is UBC. Okay. Anyone? Dr. Ronak?
This appears to be a simple bone cyst with a falling leaf sign.
You can imagine that I'm your examiner. You're giving your table viva. Now answer.
Appears to be a
and first describe. See, that's what I told you. Okay, have this habit. Okay, don't jump on the diagnosis of simple bone cyst. How will you describe this X-ray? So this is an X-ray of an immature skeleton, shoulder. Yeah.
X-ray of the left shoulder. With, showing proximal humerus with a cystic lesion in the metaphyseal region.
Yeah. Central, eccentric, central. Lytic lesion.
Appears to be centric with a breach in the both cortex.
Correct.
With cortical fragment in the center of the cavity.
Yeah. Also called as
falling leaf.
Correct. So then APV of the shoulder, immature skeleton, metaphyseal area, centric, lytic, expansile cortex, fallen leaf sign, SBC. Anyone? Dr. Dipin, I know a few people only. Yeah.
Sir, this is X-ray of right shoulder of a skeletally immature individual, showing lytic lesion in a metaphyseal region, which is centric. And
so exactly why I'm doing this, because then you get that habit of speaking. That is the APV of the shoulder in an immature skeleton showing a lesion in the metaphysis, which is centric, which is
there is lytic lesion.
Yeah.
Suggestive of ABC.
Okay. Describe always the matrix inside. If you're not able to, you can skip that. It's not always necessary. And the cortex. You can definitely see the cortex around the lesion is thinned out. It is expansile, bloated up as compared to the remaining part of the bone. So describe that, and then you can go to your diagnosis. Okay. So then SBC again. Okay, I'll give you this. Okay. So APV of the skeleton, immature skeleton, metaphyseal area, lytic lesion, sclerotic rim. You can see the sclerotic rim, like, yeah, cortical thinning, no breach, no periosteal reaction. There's a fibrous cortical defect or difficult. So, anyone? The madam in red. Yeah, you. Give her the mic now. And we are not asking for the diagnosis. We are asking for the description of the X-ray. Okay? Yeah.
The anterior, posterior, and lateral view of a knee showing proximal tibia and fibula of immature skeleton with a lesion in metaphysio-diaphyseal junction, which is lytic, geographic, and eccentric.
Correct. Absolutely. With the cortex here is absolutely normal. Okay, there's no problem with that. And no periostal reaction. See, these are the headings which will give you more wordings, more time. You better describe those X-rays. Okay, the non-ossifying fibroma X-ray. Okay, there are multiple X-rays given to you. A doctor in checks. Yeah, the yellow one. Yeah.
X-ray, anteroposterior X-ray of an immature skeleton showing a skull, spine, and femur diaphysis.
Yeah.
With a diaphyseal lytic lesion in the 2/3 of the diaphysis.
Yeah.
Lytic and with no cortical erosion. Central.
Anything else? अभी हर बार हमने no लिखा था ना उस चीज के लिए.
It is
there is a good amount of periostal reaction here, which is seen. Okay. Anyone? Diagnosis? Yeah, correct. Eosinophilic granuloma. There's a triad, no? Skull, spine, femur. Yeah. The one in blue over there. Yeah. You. Yeah. This is easy.
This is a plain X-ray of the bilateral femur with the pelvis.
Yeah, so both hips, thighs, and knees, everything for you. Yeah.
Showing permeative geographic lesions of extending over the whole femur.
Okay.
No.
So multiple lytic lesions. Yeah.
No periostal reactions are seen.
Yeah.
Geographic lytic lesions.
Yeah, lytic lesions all throughout both the femurs. Okay.
Yeah, with shepherd crook deformity.
Okay.
And ground glass appearance of the cortex.
Absolutely correct. No. Yeah, what I mean to say is, don't hurry to the shepherd crook deformity. We all know that you know that. Okay. Yeah. Fine. So the polyostotic fibrous dysplasia. Dr. Shiv Prasad.
It's an X-ray of anteroposterior view of the pelvis with both hips.
Yeah, be a little louder. Yeah.
With a lytic lesion, centrally placed, with non-sclerotic margins affecting the metaphysis, and trabeculations are seen, and a geographic lesion.
Okay, so geographic lesion, no sclerosis, ground glass matrix, cortex thinned out, expanded, no periostal reaction. Again, shepherd crook. This is also a case of fibrous dysplasia only. Okay. Yeah. Dr. Bharat.
It's a anteroposterior and lateral view of wrist X-ray with lytic lesion in the
X-ray of the wrist, mature skeleton. Yeah,
in a mature skeleton with a lytic lesion with septations, with thinning of cortex with expansile lesion, mostly suggestive of giant cell tumor.
Correct. So epimetaphyseal area, eccentric location, lytic lesion, geographic distribution of matrix, cortical thinned out. It's a giant cell tumor in the wrist. Okay, I'll give you this. No. AP and lateral of the knee showing distal femur, proximal tibia and fibula in a mature skeleton, epimetaphyseal area, again lytic, geographic lesion, well defined, cortex expanded, again a GCT of the proximal fibula. Okay, I want someone to take this. The last one. You. Huh?
This is an X-ray of tibia and fibula of a mature skeleton, suggestive of a cortical defect located eccentrically with a...
Located in the diaphysis. It is central. What do you feel?
Central.
So it's cortical. Eccentric. Okay, fine. I'm giving you now. Chalo.
Blastic and well-defined area with the cortical hyperostosis surrounding the lesion.
Yeah.
Osteoidostoma.
No periosteal reaction. Classic history, osteoidostoma. Okay, this is what we also discussed in today's one of the cases. So this is how your osteochondroma looks like. Okay. So again, metaphyseal, sessile or pedunculated, no periosteal reaction. I'm not hurrying up where there is not that so much of. So this is again how an enchondroma, the cartilaginous lesion into the diaphysis. Cartilaginous punctate sort of calcification which are seen into the diaphyseal area. Absolutely preserved cortex, no periosteal reaction. Okay. Sometimes it is not there, you should tell. Okay. So that gives you a better way of explaining the lesions. Anyone? A doctor in black and yellow stripes. Yeah. If you're getting bored, let me know. Yeah.
This is a anteroposterior X-ray of the distal femur and knee of immature skeleton, showing a lesion in the diaphyseal area.
Correct.
With a periosteal reaction.
Yeah.
And
I'm asking you something because you said periosteal reaction. What type of periosteal reaction is this?
This is
sort of correct.
Laminar type periosteal reaction.
Yeah.
And there is a
cortical thickening.
Cortical thickening and no medullary involvement.
That medullary involvement is written by the previous person. I was a little not sure about it. Okay. So this is an Ewing, this is a case of an Ewing sarcoma. Okay. The proper periosteal reaction, diaphyseal location, immature skeleton. Okay. The madam sitting over there. Kushagra, hand over the mic. I'm just covering those topics which will not be covered in the cases. Okay.
This is the AP and a lateral view of the knee, where we can.
Oh, sorry for that. Huh? It's not shoulder. Yeah.
Of a mature skeleton, we can see a periosteal reaction on the lateral border of the femur.
Lateral or do you want to?
Posterolateral.
Yeah. Okay.
It's in the metaphyseal region. And,
yeah. So this is a very classic X-ray. Okay, of a particular type of lesion. So this. Okay, fine. I'll give you. This is the AP view of the knee, the mature skeleton, metaphyseal location, paraosteal lesion, blastic, geographic, well-defined, no other bony changes. This is a paraosteal OGS. Okay. Okay, I will go a little faster. AP view of the femur with knee in a mature skeleton, diaphyseal, cortical, mixed lytic and blastic, ill-defined borders, cortex thinned out, periosteal reaction. You can appreciate the Codman's triangle. Yeah. Malignant features. What can this be? Periosteal osteogenic sarcoma. Yeah, that's also similar to that. Okay. The one next to Shiva. Yeah, Prince.
This is an X-ray of distal femur and pelvis with both hips.
Yes.
In a skeletally mature patient with adequate exposure. There are punctate calcification in the metaphyseal region with lysis, lytic and sclerotic changes, and in the left iliac bone. Most likely to be an chondrosarcoma.
Correct. Dr. Rupam?
There is an X-ray of right shoulder with lytic lesion centrally located over the
central location.
One is over the near the GT, and another is near the mid shaft.
Okay.
With fracture of the medial border over the shaft.
Correct.
and with
You can
generalized,
appreciate the cortices are really thinned out all around.
yes,
Okay.
generalized osteopenia with thinned out cortices.
Correct.
And
I wanted you to tell me that. Okay. So you can appear the matrix is moth eaten over here all throughout. Diagnosis, anyone? Yeah, some of you may feel this is permeative, right? Yeah, so this goes a little no. So there's a metastasis with a fracture. Anyone? I don't have to say anything else, right? After this? Yeah, Dr. Chandan, you can answer this for us. He's been really hardworking, yeah. Chandan, we are giving this opportunity 1 year prior. Yeah.
Sir, this is a plain radiograph, anterior posterior view of both right and left hand with wrist. Immature skeleton.
It's okay. No,
there is a widened distal ends of both radius and ulna.
What is this, Chandan?
Decades.
So, thank you. Yeah, so the classical flaying, cupping of the metaphysis, widening of the growth plates, coarse trabeculations, rickets. Again, a PA view of the wrist, immature skeleton, widened distal end, resolving sort of metaphysis. So this is a case of healing rickets with a distinct zone of provisional calcification within the physis. Okay. Anyone? Dr. Shiva, Chahal.
X-ray of the shoulder with the skeletally mature child.
Yeah.
With showing type 1 Salter-Harris or physeal separation.
Very good. Very good. Correct. So this is exactly a type 1 Salter-Harris type of fracture. The first one. Yeah. Again. Diagnosis, chalo, patapat. No? Doctor in black? The one, yourself. Yeah. 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 Salter-Harris type 2. Correct. So, Salter-Harris type 2, Mills type 2. And that's a classic Thurston-Holland fragment, which is seen along with it. This one, which Salter-Harris type? So let's move fast. Dr. Sahil, which Salter-Harris type?
So type 4.
Type 4. Okay, going all the way, above to below. This is that of Mills type 2. This is Mills type 1. Okay, and Salter-Harris type 4. Anyone? Normal X-ray? Type 5 Salter-Harris. Okay, anything else? Yeah, this is a special type of fracture. This is a triplant sort of fracture, okay, which is seen in the ankle. Okay. Anything particular about this X-ray? Yeah, be a little louder, Animesh. Animesh hi naam hai na? Haan. What you are saying is correct. What? So what do that indicate?
Gas gangrene or an open fracture.
Open fracture, correct. So that's an infection and an open fracture. The gas shadows which you see in the X-rays. Okay, correct. Commonest. Chronic osteomyelitis with a proper sequestrum, involucrum inside, sequestrum, sorry, not involucrum, with an abscess. So you'll be asked all the type of sequesters on this. Charcot. Bony ankylosis, no, all the way throughout. No? Trabeculations going all the way from the tibia to the calcaneus. Okay, that's bony ankylosis. Okay, last few X-rays remaining now. Anyone wants to take this? Anyone? That's an osteochondroma. Check it in the lower part. Which type? More of the type, not a peduncular type. Easy. Correct. Posterior dislocation with a wall fracture. Okay. Yeah, that's all for you.